Thank you for having us. I'm Annie Kennedy. I'm the Chief of Policy, Advocacy, and Patient Engagement at the EveryLife Foundation for Rare Diseases. I'm delighted to be here. And I can just give you some history on how we came into this space and work, and how then this blog came to be, and then hand it off to Dr. Joni Rutter from NCATS. So just some background. EveryLife is a coalition organization focused on policy and rare diseases. And about 2.5 years ago, working with our coalition partners and patient advocacy organization leaders in the rare disease space, we really identified an information gap. So individuals and families living with rare diseases well know the financial impact and the financial toll it takes on a family who is living with a rare disease. So once you receive a diagnosis, much of what is prescribed to a family, much of what is required to live out your journey with a rare disease is not reflected in the medical bills or your explanation of benefits. So while those costs are certainly significant, many of the costs incurred by families are out of what we refer to as out-of-pocket costs. The cost of modifying your home, the cost of modifying a vehicle, the cost of filling prescriptions or purchasing items that are prescribed by a medical provider but aren't reimbursed in the healthcare system, or even the cost of having to leave the workplace because you're a caregiver for a family member, or you can no longer work full-time because you're a caregiver, or you have to dedicate some of the time at work making medical appointments, navigating the healthcare system, which we refer to as productivity losses. And what we never had before was a study that actually took all of those costs, or those cost estimates, those back of the envelope calculations, and actually collected real data around that. The other thing we didn't have real good data around was how many people are actually living with rare diseases. What is that real impact to the US for that economic impact of rare diseases, or in health economic terms, we refer to that as the burden of rare disease. Not because anyone who lives with rare disease considers it to be a burden, or a family member considers it to be a burden, but in health economic terms, we refer to that as the burden of a disease or condition. So we set out to do that study. And along the way, as we were doing the study, and we can talk about the methodology and what we learned that some other partners were also doing similar work. So one of the things we did as a community is we didn't want to be doing it alone. We also wanted the Government Accountability Office to do a study. So we led appropriations work, the GAO to do a study, and that work that went into the appropriations bill, and the GAO was conducting a study as well. So we were really grateful for that. We also partnered with NIH, and we learned that NIH was conducting a study, and we learned what their timeline would be. And so once all these studies began to come out, it was really important to us to watch what the methodologies that were different from one another were, and to watch the findings to see whether those findings from these studies would validate one another. And then at the end of the day, as advocates, as rare disease advocates, we wanted to make sure that the findings from these studies would leverage policy changes. We didn't just want this data for the sake of having data, but from the sake of EveryLife, we want something to change at the end of the day. So that's just sort of to tee up the conversation, what EveryLife's motivation was, and why it's really exciting for us to be on here talking to you about this health affairs piece. So I'll turn it over to Dr. Rutter.
Well, thank you, Annie. My name is Joni Rutter. I am the Acting Director of the National Center for Advancing Translational Sciences, or as we like to call it, NCATS. And NCATS is the newest institute or center within the NIH. We're 10 years old, actually, almost to the day. We're a little 10 years and 2 months. And we were founded initially at the NIH to turn basic findings into health solutions. And a part of what we do is we work within our clinical and translational programs through the CTSA program or the Clinical Translational Science Award program, a large network of clinical and translational academic organizations across the country. And we work with a a wide variety of rare disease organizations as well, and networks across the country through a program called the Rare Disease Clinical Research Network, or RDCRN. And we have a number of programs in preclinical translational science, as well as the clinical programs in translational science. And our whole goal at NCATS is to bring more treatments to all people more quickly. And when you think about the number of diseases out there, we think there are about 10,000 diseases out there, and most are rare diseases. About 7,000 of those, and even more, growing number, are rare diseases. And these are diseases that affect fewer than 200,000 people within the US. And it also means that there is then this idea that they are rare for any given particular disease. But in reality, the rare diseases are not rare because it affects about 30 million people within the United States. So the problem is that most rare diseases are what we call ultra rare, which is maybe up to 10 or even hundreds of people who have that particular disease. And this makes it incredibly difficult for our healthcare systems to keep track and to even define rare diseases using these sort of standard clinical codes that are used, called International Classification of Diseases, or ICD codes. And the impact of this is that then rare disease patients are at very least sort of undercounted in our healthcare system. And so they're in a sense invisible. And so just like Annie was mentioning, our idea was to look at this problem as well, the sort of burden of rare diseases, because we do think that rare diseases are a public health problem. There is a burden of disease. There is a burden of disease outcome. There's a magnitude of rare diseases when you consider them collectively. But we didn't have, as Annie said, we didn't have a way to put a number on it and really show the stark reality of how to quantify rare diseases in the system. So we took a similar but very different kind of approach in how to start with the healthcare systems, how to access them to find rare diseases, and then try to understand and quantify the number of rare diseases and the patients, for example, within a given rare disease. We studied 14 of them because we could select 14 rare diseases within the healthcare system somewhat reliably. As I mentioned, it's very difficult to identify them in the healthcare systems, but for 14 of them, we felt like we were pretty comfortable to get the numbers needed to really get a good sense of then understanding the magnitude of the costs. And so what we did was we ended up quantifying the number of rare disease patients in these categories, in these 14 different rare diseases, and evaluated them in their direct medical costs to those who did not have rare diseases, who were also in the medical care system. And so they were a matched control group, so to speak. And what we found was that the rare disease groups were 3 to 5 times higher in their direct medical care costs, totaling to around $400 billion in direct costs per year. And as we started to really compare what EveryLife had done in their study and the GAO, and then other information that we were looking at, those numbers were striking. They were close, and so we really felt that this was we're getting to something that we're able to start to quantify the number of that medical direct costs on rare diseases, and that number is staggering. $400 billion per year in medical care costs is quite large. So in a way, that's why we got together. And really wanted to join forces to see how we can really start to think about what are the specific needs now and how we can move forward.
Yeah, and so I think one of the things that's really important for us as a community and as a patient community when we look at these studies is, so as Dr. Rutter said, our numbers lined up really closely when you look at the direct medical costs. For our study, it was important to us to look at 3 cost categories. So we looked at direct medical costs, and as Dr. Rutter said, we were very close in the direct medical costs. One of the areas that our studies are a little bit different is that we also looked at indirect and non-medical costs in our study. And we were really grateful to be able to do this. It was a novel study design in that we were partnering with the patient advocacy community as we did our study. And so we were able to work with patient advocacy organizations to design a survey to understand what were some of the impacts of living with a rare disease and the costs that are being absorbed by families outside of the healthcare system. And we surveyed the patient community to assess that and create an algorithm to really look at that from a quantifiable way. And what we found was incredibly important. So we were looking at data from 2018, so before the pandemic. And what we found was that 60% of our overall costs in the rare disease community are not coming from those direct healthcare costs. So our findings from our study overall were that in 2019, the economic impact of the rare disease community, and we looked at 379 diseases, and that was based on the survey respondents, the diseases that people who responded to our survey were living with, that overall impact was close to $1 trillion. I'm going to repeat that in 2019, the economic impact of rare disease was $1 trillion. But the bigger piece of that story is that 60% of those costs were costs absorbed by families. 40% of those costs were costs that we saw reflected in the healthcare system. And those numbers matched up in all of these studies that we were able to compare and sync in the health affairs study. So we were able to validate each other's findings there. To us, what's incredibly important are a couple things. First of all, to understand where the cost drivers are, whether we're looking at direct costs and when we're looking at the costs being absorbed by families. And then to look where there are opportunities to shift those costs, reduce those costs for families, and change the conversation we're actually having. Because rare disease is expensive. This is a really hard conversation to have because it's already costing Americans. But what it's costing are people who are living with rare diseases. So when someone receives that diagnosis, what we're saying to a family is that the way that you will thrive and survive your rare disease very much depends on your ability to afford living with your rare disease. Because what we found in our data was that 60% of this cost is going to be incurred directly by that family out of their pocket. And so we have to do better by families. We have to do better in our system. And we further were able to dig down deeper and see where some of these cost drivers were, both within the direct data, but then in other places. And so this policy piece, this paper that we did, really point to what we consider to be some policy solutions that are low-hanging fruit, where we could really make a significant impact for the rare disease community, for the scientific community, for the broader American population, if we really just use the science, the innovation, the resources we have at our disposal and employ them now.
And if I can add to that as well, in a way, NCATS's whole idea is in bringing more treatments to all people more quickly. The way that we can do that best is to understand the pipeline of taking a basic finding, taking it through the preclinical and clinical translational science to get it to a clinical application. And through that process, though, it's a difficult process. It's not straightforward. And for NCATS, we want to understand where the crimps are in that pipeline so that we can address the crimps and make things move more quickly. And so when we talk about how we can affect this change that Annie is mentioning, there are a variety of ways in which we can approach it. And one of those key factors, I think, that these studies all point is the need for really shortening and addressing the diagnostic odyssey that it takes for rare disease individuals or patients to get diagnosed with a rare disease. And even then, there are hurdles in the system because we don't have these ICD codes for every one of them. And so I think one of the things that this Health Affairs blog has highlighted is this need to address the diagnostic odyssey. And the reason that that's important is not only because it takes 6 to 8 years to, on average, it can take more or less to get diagnosed if you have a rare disease, but it's also understanding that when you do have that diagnosis, if you are misdiagnosed along the way, you may be treated for something that's not effective or can actually be harmful, or that time it takes might cause you to miss the window for getting more appropriate treatments that could modify the disease. These would be game-changing, modifying therapies for that particular rare disease. And so it's critical that people with rare diseases get that diagnosis early so that there can be an appropriate plan for that healthcare moving forward. And I think that's another piece where in all of these factors that we're mentioning today, that diagnostic odyssey is, I think, one of the bigger things that we can make tangible, try to understand how we can decrease that diagnostic odyssey using new tools and resources that we can employ within our healthcare systems. But we have to find a way to get traction in that. And so another thing that NCATS is trying to do is to support research that would enable investigators to think about using the healthcare system as a way in which to identify rare diseases faster within the system itself. And the importance of that then would be to get a foothold in a particular system and then to validate that in other systems, and then perhaps implement that or disseminate it in more healthcare research systems or healthcare systems to make that diagnostic odyssey shorter than it is now. So I think those are some of the things that we can really start to address even more quickly than other areas.
And maybe if I could just, punctuate that point for you, and then maybe even tee you up to talk about opportunities to expand access to some of the diagnostic tools we have. But so in the economic burden of rare disease study that EveryLife led, we found the findings that were really elucidated by the rare disease community. We found that the mean diagnostic odyssey was 6.3 years for respondents. But even adding another layer to that, respondents, the average diagnostic odyssey included visits to 17 clinical specialists. And when we dug down deeper to look at who those specialists were, it included on average 4 ER visits, 2 hospital admissions, 2 out-of-state provider visits, and on and on and on. And anyone who's a part of the rare disease community understands that first of all, there are huge costs involved in any of those visits. There's a lot of healthcare tenacity required in order to make it through a diagnostic odyssey of 6.3 years like that. That's a lot of asking for second and third and fourth opinions and doing a lot of research to understand where you go next. In the rare disease community, we have a highly Medicaid eligible patient community. There are a lot of barriers to going out of state for a specialist and crossing state lines. So to go to out-of-state providers, that is often not reimbursed, or it takes a lot of advocacy to get to that out-of-state specialist or care center or center of excellence. So one of the things we worry about in these numbers is that while 6.3 years and 17 specialists sounds really heart-wrenching, and it is, and as Dr. Rutter just said, we're talking about oftentimes irreversible disease progression and damage happening in the meantime. What it also means is that we are introducing health inequities for a number of reasons when we have these diagnostic odysseys in our patient communities. And so we worry about who's not represented in these numbers, who hasn't yet gotten a confirmed diagnosis, which communities are being left out or left behind. And so we really are very committed to looking at what tools we have available today to ensure that a diagnosis is not out of reach for broader patient community, and that we can be working with providers, point of care providers in the primary care setting to ensure that whether it's in the newborn period and we use the existing public health systems and modernize that, or if you have a diagnosis that presents outside of 6 months, later in childhood, later in adulthood, we can detect and screen and diagnose for that as early as possible and optimize outcomes. So maybe Dr. Rutter, you can talk a little bit about some of the work that NCATS and others are doing around this.
Absolutely. Excuse me. Absolutely. So, making a dent in the diagnostic odyssey and looking at these health outcomes, I think is a key issue. I'm probably going to go on a tangent here in a moment, but I was thinking while you were talking, I was also thinking about, it's one thing to have these tools to help us identify people or make rare diseases more visible in our healthcare system. It's also another approach in terms of the research that I think that is starting also to be much more streamlined and available is whole genome sequencing, and the ability to use tools like that to also identify and start to diagnose rare diseases, because oftentimes those rare disease diagnoses come from a finding in a whole genome sequence. And that's how we're finding more and more rare diseases, because of these defects in the genomes that are causing the rare diseases. And so I think that the more that these tools are more widely accepted and accessible to hospitals and researchers, and that the rare disease community is able to identify how to access those diagnostic areas in terms of that is part and parcel of what's going to help us too. And I also just wanted to kind of think about why that's important from the diagnostic perspective to move us into the treatment side as well. Because with 7,000 rare diseases, and if we were to approach them one disease at a time, that will take us thousands of years to find treatments for each of these rare diseases. And understanding the diagnostic odyssey, being able to shorten that is helping us identify what's causing those rare diseases. And as I am alluding to, oftentimes those causes are related to a genetic defect. And we are in the research community, we're getting more and more savvy and familiar with how to use tools that can start to address those genetic defects and even fix them within someone through gene P or through gene editing types of approaches. And so this diagnostic odyssey leading to then understanding the diagnosis and the mechanism of how those are causing diseases will lead us then into better treatments and more available treatments for a wide number of rare diseases that may not be specific to a given rare disease, but because of what's causing the rare disease, we might be able to affect a large number of those 7,000 rare diseases through those treatment kinds of approaches. And so I just wanted to make sure that there's the reason that diagnostic odyssey is so important, and identifying people in the rare disease patients within the healthcare system will lead to those better treatments, I think. And I'm really excited about some of the programs that NCATS and the NIH are a part of in terms of how to enable gene therapy and gene editing types of approaches and other gene targeted therapies. And I think this is really, over the next decade, we're going to see that this is something that's going to be game changing for the rare disease community.
That's
Annie,
great.
I'm not sure if I answered your question though.
I think you did. I mean, I think it also points to, we also, as we were looking at these studies and some of the themes in the studies, we also really looked at some of the learnings that we had as we were all conducting the studies. And one of the things I think we found was that the lack of having, you earlier referenced that patients are invisible in some of our healthcare systems. And one of the reasons for that is the way that we track individuals in healthcare systems and in data sets is through what's called an ICD code, which is a code. The ICD stands for the International Classification of Diseases. And in rare diseases, while we have an estimated 7,000 to 10,000 rare diseases, only about 500 of those rare diseases have ICD codes. So that's a real limitation when we're looking within data sets, or we are, more importantly, an individual living with a rare disease, trying to track your healthcare across the different systems you may be in, whether it's registry or surveillance, or you're seeing your primary care doctor in one health system and you have an ER admission in a different health system. There are a lot of reasons why having a code unique to your rare disease really helps integrate all of your data. I like to think of an ICD code as like being like a hashtag, sort of helps unite and follow you. And so one of the things that we really looked at as we were looking at all these studies are how can we introduce efficiencies into the work that we're all doing? And so, introducing processes for updating ICD codes would be one of those efficiencies. We also really thought that enhancing data collection to include the way that EHR data is being integrated into the many different registries and surveillance systems would also be a really important opportunity in rare disease, so that data can talk to each other and that their data is not being kept into silos, whether that's clinical trial data or against surveillance data or natural history data, because we have limited populations of patients, and we want to make sure that we're able to track and follow and understand the community experience. So again, we thought there were some real opportunities with the science and innovation that we have to really create some efficiencies that will benefit the patient community today, immediately, and that we were able to bring these studies together and identify some of them with the learnings from our experiences.
Yeah, and in I think mainly those talk about the ICD codes that you mentioned, and establishing those for more rare diseases is so important. We've also talked about enhancing the collection of the rare disease patient information, and I think including that in more of the types of surveys that health surveys that are conducted in larger cohort studies, and making sure that rare diseases are present in those sorts of things to get a sense of that integration in the broader context of health and the environment. And expanding access to the diagnostic tools you mentioned earlier, and I think one of the reasons I wore my scarf today is because I do think about the zebra trigger, what we like to call how can we identify individuals in healthcare systems better, and one of the things that we like to talk about is something called a zebra trigger. If a physician is working within a medical record system, could there be a way in which we could have a tool built in where they might identify a rare disease patient better or faster because of certain indicators within that medical record, such as what Annie mentioned earlier in terms of seeing the rare disease patients tend to see lots of physicians. 17 physician encounters, I think, was the number that Annie mentioned earlier, as a typical number that a rare disease patient sees. And so if that can be sort of highlighted, this patient has seen a variety of number of physicians, that could be a trigger that says, hey, I might have something that is not so common, and it might actually be a rare disease. And so that would help a physician kind of see or make that individual patient more visible within the system. So that's, I think, another area. And then thinking about the natural history studies and other types of ways in which we can help support what a rare disease looks like, how we can identify their symptomology along the way that might be more indicators of understanding the rare disease. And then ultimately really structuring the electronic health record to enable the indicators within them in the structured data in the fields that are supported in electronic health records to identify those rare diseases. So I think these are the main key recommendations that we've been discussing, and I think are so important for us to start to move the needle and really make a difference in the rare disease community.
Yeah, so I think ultimately, maybe just to sum it up, I think, as you said at the beginning, what we are seeing is that rare is not rare. that we really have established through this data, I think what many of us in the community have long felt, that rare diseases represent, an urgent public health issue, and for some of us, what we would consider a public health crisis that really deserves attention and resources that match that urgency. And that this is something with the data, with what we've really been able to establish, is not somebody else's problem. It's all of our concern, all of our issue, and something that really we cannot look away from. And our goal with doing this work was to really develop evidence upon which we can anchor some real policy solutions and begin to wrap our arms around where those policy solutions can be pointed at and aimed towards, and understand the extent to which a rare disease diagnosis impacts families and communities financially. We now have that data. We have some future directions for digging down a little bit deeper. But we believe very strongly, the rare disease community believes very strongly, that we need increased funding for research, for enhanced awareness and resources to improve access to, as we've been talking about here today, timely diagnosis, care, identification of patients and the interventions that are warranted, and treatment. And so we're just very grateful for all the partners who worked with us together to bring these reports together and work together on policy solutions so that, as Dr. Rutter said, we can move the needle for our collective patient community.
Here, here, Annie. Conversations with you, with organizations, with industry, with biotech and pharma, with other federal partners, FDA, with patients and patient advocacy organization. This is what it takes. And we're excited that this conversation is happening. Thank you.